Good morning, everybody, and welcome back to Journal Club. Today we have a hopefully very exciting session in store for all of you. So it gives me great pleasure to present that today Iacopo Muraca from Firenze will be the fellow discussing the article. And as expert, we have Professor Giuseppe Biondi Zoccai from Sapienza in Roma in Italy. The topic of discussion today is, let's say, quite the hot topic about cusp overlap, which you might have heard in many different contexts with regards to TAVR, but today we'll be focusing on the article which looks at cusp overlap for pacemaker implantation. We know that pacemaker implantation is an important issue as we move to low-risk TAVI, so we'll give a few more seconds to the poll, which says which of the following reduces pacemaker rates in TAVR, and most of you have answered higher implantations, which obviously leads to the question, how can we achieve higher implantations? And Iacopo, I'm looking forward to you telling us this paper and a bit more about this field. So please take it away.
Okay, good morning to everybody. First of all, I would like to thank Gisa Young for this great opportunity and Professor Giuseppe Biondi Zoccai for joining us in this session. Just a brief introduction. As we know, conduction abnormalities requiring permanent pacemaker implantation remain a common complication after TAVI, and this is mainly due to the close proximity of the atrioventricular conduction system to the aortic cannular plane, which is the landing zone of transcatheter heart valve. These clinical complications are likely to be of increasing importance as TAVI has expanded this indication in younger and lower risk population. Therefore, it is necessary to apply any effort and any strategies to allow to minimize this kind of complication. Nevertheless, the association between pacing after TAVI and long-term prognosis is still controversial. One of the most popular strategies developed in the last few years is the cusp-overlap technique, which consists in modify the implant projection, achieving a superposition of the left and right coronary cusp. This is obtained usually moving from a left cranial projection to a right caudal projection. The main advantages of this technique are the possibility to obtain a non-coronary cusp well isolated, the elongation of the left ventricular outflow tract, to achieve a better alignment of the delivery system, eliminating parallax, and last but not the least, a better coronary commissural alignment. All these features translate in facilitating to reach an optimal implantation depth. In fact, in the last few years, a lot of studies were published showing that a higher implantation depth is independently associated with a less incidence of permanent pacemaker implantation after TAVI. Here I have reports some example for you. So the main purpose of the study that I'm going to present you is to evaluate if there is a correlation between the adoption of cusp overlap technique with higher implantation depth and consequently a lower incidence of permanent pacemaker implantation compared with classical coplanar view. This analysis was conducted specifically in self-expanding valve on Evolut platform. So the study design, this is an observational and prospective study from two high-volume centers. Patients were enrolled from February 2015 to February 2021. The inclusion criteria was a subject chosen for TAVI with self-expandable Evolut platform. 594 patients were screened and 150 were excluded according to the exclusion criteria. So 444 patients were analyzed. The primary endpoint of the study were transcatheter heart valve implantation depth and permanent pacemaker implantation and 30 days. The secondary endpoints were the occurrence of high-degree atrioventricular block and any safety issue according to VARC2 definition. After procedure, all patients underwent continuous electrocardiographic monitoring for at least 24 hours, and patients were referred for permanent pacemaker implantation according to 2018 American guidelines. Regarding the implantation depth, it was evaluated according to the three most common methods: the arithmetic mean of the measured distance from the non-coronary cusp and left coronary cusp to the distal part of the stent of the valve, the non-coronary cusp distance from the distal part of the prosthesis, and the deepest edge from the distal prosthesis end, regardless of the anatomic orientation. Talking about the result, this is the result of the primary analysis, the preliminary analysis performed on the overall population. As we can see, the procedural success was high in all two groups. According to the primary endpoint, cusp-overlap technique was associated with a lower incidence of permanent pacemaker implantation compared with the classical coplanar view group. Regarding to the implantation depth, even in this case, cusp-overlap technique resulted associated with a higher implantation depth according to non-coronary cusp to distal and measure method. There were no differences in the secondary endpoint, and in particular, any safety difference between the two groups. The main analysis was instead conducted after a propensity score matching according to all baseline characteristics. As we can see in the graphic on the right, the baseline characteristics were well balanced between the two groups, with the minimal standardized mean difference between the group, as we can see from the red dot on the graph. Here we have the result of the analysis on the matched population. Even in this case, cusp-overlap technique was associated with a statistically significant lower incidence of permanent pacemaker implantation after TAVI procedure. And also in this case, implantation depth assessment showed a higher implantation depth in the cusp-overlap group according to non-coronary cusp to distal edge method and arithmetic mean method. Also in this analysis, there were no differences in the secondary endpoints between the two groups. A logistic regression analysis was also conducted to assess the role of lower implantation depth and risk of conduction abnormalities. As we can see, lower implantation depth was associated with complete or high degree atrioventricular block and with intraprocedural complete atrioventricular block. In the table down on the right, I've reported the main cause for permanent pacemaker implantation in the two populations, and as we can see, the main indication was complete or high degree atrioventricular block in all the two groups. In order to strengthen the result of the analysis, the authors have performed a sensitivity analysis, obtaining a new matched population controlled only by two variables: the presence of pre-existent right bundle branch block and the age, which are two well-recognized predictors of permanent pacemaker implantation after TAVI procedure. They obtain 174 pair of patients, and even in this case, cusp-overlap technique resulted associated with a statistically significant lower incidence of permanent pacemaker implantation and a higher implantation depth compared with classical coplanar view, according to non-coronary cusp to the distal edge method. The E value was also calculated, even in this case, to obtain a sensitivity analysis. The E values substantially consist in the evaluation of the minimum relative risk that an unknown or unmeasured confounder should reach to overcome the association between cusp overlap technique and a lower incidence of permanent pacemaker implantation. In this case, obtaining a value of 3.1, there is a quite high value. So confirm the result of the study. According to the author, the main study limitation were the observational nature of the study, the retrospective analysis of implantation depth measurement, and the fact that this study was focused on a particular kind of TAVI platform and specifically Evolut self-expanding valve. So, in conclusion, there are currently no randomized controlled trials that have assessed the impact of a cusp overlap technique on implantation depth and so the need for a permanent pacemaker after TAVI procedure. This study demonstrates that thanks to the cusp overlap technique, it's possible to achieve higher implantation depth without concerning regarding feasibility and procedural safety and patient outcomes. And the use of a cusp overlap technique was found to be associated with higher implantation depth and about half of permanent pacemaker implantation compared to the conventional implantation technique. Thank you.
Great. Thank you so much, Iacopo. Very nice summary of this article. Professor Biondi Zoccai, can I please invite you in now to give us your perspective on this article and this field? And then we'll take questions from the audience if anybody has questions, and then go further with some discussions.
Well, many thanks. I'll try to be brief so that there is room for discussion. Of course, this is very interesting as a study because it provides a very simple and catchy, in a way, potential solution for this problem. Of course, it's a non-randomized study, two-center, which is almost like a single center. I think it is also a nice case study of propensity score. So basically, anybody of us who's doing a study which is not randomized should use propensity or should have a valid reason not to use propensity. We will possibly focus on some of the technical aspects of propensity score analysis in the next few minutes. But I think it's very interesting. The two issues I have with the study are mainly the potential role of missing data and unmeasured confounders. But if I can provide a very brutal and short critique, I'm quite old and I've seen many studies, it's very uncommon to have interventions which reduce so much the risk of something. So it's very uncommon. And this calls from some caution. But clearly the idea is very appealing and likely to be successful. But now let's have some discussion, please.
Great. Okay, thank you. So let's start with, first of all, questions. If anybody has any questions about this field or the conclusions, specifically, we will be discussing the concept of propensity score matching in a little while, definitely. But if anybody has any questions about this field or this topic, please feel free to ask. If not, I can probably start with one that the cusp overlap is being talked about a lot recently, both to reduce pacemaker rates, higher implantation, also for commissural alignment. In experience, how practically feasible is it to achieve this? How easy is it to do this in cath lab? Sometimes the projection can be a little bit extreme, particularly in an obese patient, and it can be difficult to achieve that areocaudal view. So is this something that's easy to do in cath lab and easy to bring into your practice? Because I've also heard some operators say that it's impossible. I can't deal with this. It's too difficult. So, how easy is it for people to change to do something different like this?
In our experience in our center, we are trying to making it our standard, in particular for self-expandable valve. As you told, sometimes the projection is not so comfortable for the operator because we have to move very caudal and in a very right projection. Sometimes we try to use a near cusp to obtain a more comfortable position to work. sometimes I have to admit that we implant in conventional tricuspid view with coplanar visualization.
Okay, thank you. Then there's a very nice question from Pierluigi about what angiographic projection was used to calculate implantation depth.
Yes, as I write in the study limitation, the implantation depth was retrospectively analyzed, and there were it was measured by angiographic views, but there was no standard projection. The author state that they use a projection which eliminate foreshortening of the valve, so eliminating the parallax, but there was no standard projection. Certainly, the utilization of post-procedural CT, I think it was the gold standard for this kind of measure.
Okay, great, thank you. So unless there's any other questions, Professor, can I please ask you then there's a lot of, basically it's all young fellows who are connected, a lot of people are starting research or, doing research at the moment. Can you please give us an overview of propensity score matching in terms of, let's say, a little summary of perhaps the principles, and then perhaps we can discuss with regards to this paper, just to give people a little bit of insight into this particular statistical methodology.
Fine, sure. So it's challenging to be very brief, but we'll try to break down the main crucial things. If I may, I'll try to involve a few people directly. So first, a question for Iacopo. So is there any difference between a propensity score analysis matched whatever and a randomized trial?
Sorry,
can a propensity score study be better or worse or similar to a randomized study?
Better, I don't think. I think it's the only option we have when we retrospectively analyze data. So we have to, because registries are made from very different population that doesn't respect the randomized process. So I think is our only option to present data, good data and good results.
Okay, this is crucial. Every year in Christmas, the British Medical Journal has a comic issue, and there was a very nice article on the randomized trials on parachutes. And basically, they looked at randomized trials, didn't find any, and they concluded that hardcore evidence-based medicine believers who were asking always for randomized trials should be randomized in a trial on parachutes with a crossover design. So the key question, first of all, is whenever you can perform a randomized trial, you should do it. And there is no excuse. So basically, randomized trials, if appropriately conducted, are better. Here I see a propensity score study based on a prospective study. It's a very simple intervention. So this could have been a randomized trial. So if these were my fellows, I would have told them, you have missed an opportunity, because everybody will always be skeptical. However, there are many situations in which a propensity score is reasonable when you don't have time, when you have a challenging intervention, let's say an intervention to change sex, to change gender, or a very challenging intervention in kids, whatever, where you have logistic issues. Then you need to factor in that you cannot adjust with propensity for stuff that you don't measure. So this is crucial. If you didn't collect data on frailty, how can you adjust for frailty? Is there any way to adjust for an unmeasured confounder in a propensity score-based study? Yes or no? What's your take? This is important when you will supervise your junior colleague.
Here, the author have performed the calculation of the He value. That is one possibility. Yes,
technically, it's a good take, but the E value, from my perspective, is the other way to see to look at a very extreme effect. Okay, so if you give the thrombolysis to a patient with acute myocardial infarction or placebo, it's unlikely that you get such an extreme effect. So the value is the other way around. If you don't collect data on a given confounder, you are not going to be able to adjust for it. So basically the propensity will be frail. Another key point is what about missing data? So the nice thing about propensity studies is not necessarily to apply them to prospective studies, but to routinely collected data. Let's say VA data collected from GISE or whatever. What would you do with missing data? Let's say that you have STS scores only for 70% of patients and frailty scores only for 50% of patients. What about this missing data? This is a question I receive often from fellows who want to conduct a propensity score in studies. So any suggestion?
Iacopo, I'm going to spare you because you're getting asked a lot of questions. Marco.
Difficult point. Actually, I don't know very well, so I'm here to listen.
Okay.
Yeah, I think I would spread the thing that the data to all the population.
So this is crucial because unless the data set is perfect, which is not very common, especially in routine practice, you will have a lot of missing data. Maybe age is missing there, and ejection fraction there, and so forth. So the typical approach will be to do a complete case analysis, which means deleting patients in whom you don't have the data. This is what is typically done and what the statistical package will do. The most correct approach is to avoid missing data, whatever. But if you cannot do that, it's to impute missing data. So to create some scenarios in which you imagine the missing data according to a method. So this is very crucial because I didn't see I didn't see missing data discussed in the paper. So this is a potential weakness of the study. However, JAK intervention does a very good job at reviewing statistically the manuscripts. I don't know if anybody of you has ever published there. It's a challenging journal. So, and one question for everybody: what does propensity score do, basically? What is a propensity score? I'm asking because so people usually remember better. So the propensity score is a single number which gives an overall weight at all the potential features of the patient. And
substantially, it represents the propensity of a patient to receive a treatment instead of the other. So if there are some characteristics that are connected to the received treatment.
Perfect. So it's a single number that gives way to the attitude of the operators. So in a way, it summarizes all the operators' decision process. Take note that you can create a score also to predict the prognosis. which is called the Miettine score, which is very, very biased and has been tested, and it's very unreliable. So the propensity score is generated by typically a logistic regression. You get a number. So in the data set, you will have another column, and the column will contain this number. And then what can you do with this number? How can you exploit it to test whether a purported association is causal? In a way, I give some energy drink to people who are very fatigued, and after 1 month I recognize some people are very relaxed and energetic, and some are still very tired, and I believe the energy drink is very effective. But then I recognize that I recommended energy drink to everybody, but it was very expensive, and so it was bought only by very rich people who could take vacation and go, in nice places and whatever. So I need to adjust for potential confounders this apparent association. So how can I exploit the propensity score? Which are the potential approaches? One, we've seen it, is matching. Which are the other potential approaches to exploit the propensity score? As with any other, please.
For example, make an adjustment with the variable that we identify as potential confounders.
Fantastic. So in most cases, people will say that propensity score matching is better, but you can use a propensity score for adjustment. You can create quantiles, for example, quintiles or deciles, or you can use a propensity score to weigh each observation using what is called inverse probability treatment weighting. But the propensity score is okay. And then you can check whether the results hold true after propensity. One question, another, possibly the last one, how can you actually perform propensity matching? How do you match one patient who has received the Cusp-overlap technique with another who has not received it?
You calculate this value, this D value, for example, and then you find another match that has something similar inside an interval, a predefined interval of confidence. I don't know if I explain it in a correct way.
Yes, there are actually, unfortunately, many methods to match. Way too many. So you basically need to pick one and say, I like this. What you have discussed is using a caliper. So a specific distance, which might be very tiny or large, depending on the number of controls that you want to pick. You may just pick the closest one, irrespective of the distance. You may use the same control many times, so using replacement or without replacement. My recommendation is read the best papers you can find on propensity and copy their methods. They're gonna be likely very good.
Okay.
I think I'm done. Otherwise, we go on for a couple of days.
No, this is absolutely brilliant. Really,
Can I have a question?
Really absorbed. And yes, Giulia, go, please.
A question that I always ask to my statistician, but I can consider in this propensity match the number of variable, all the variable that I want to consider, or if I have 100 variable to consider is worse than a 20 variable, or better than, or is it impossible to consider every variable, every confounders?
So this is a crucial question. First of all, because typically when propensity score is typically generated by logistic regression analysis, in which instead of the event, you put the treatment. And we know that if you put too many covariates in a logistic model, typically it will become unstable. This is actually not demonstrated for propensity score generation. So you can put as many variables as you want. The problem are two, though. Actually three, if you are very technical. One is the missing data, because if you put too many variables, you will end up with missing data. That's for sure. I have never seen a data set without missing data, which was a large one. Second one is that you may have a problem with the specification of the variables. Okay, for instance, some variables might be not normally distributed, such as frailty. And the third thing, which is challenging, is that sometimes you would need to consider also the interactions between the covariates. So my recommendation is a brutal one. Whatever you put into the tables of the manuscript should go into the propensity score generation algorithm. But, the bottom line, if I was the boss of these guys, I would say, we are happy we publish in JACC Intervention, but if we have done a randomized trial on this, probably we would have published on Circulation, and we would have been much more conclusive. So propensity scores are useful, but also let's focus on randomized trial. Italians still perform very few randomized trials, and this is still a pity.
Okay, so I think a great conclusions at the end. So it just leaves me to say thank you, Iacopo, for presenting this article and sharing this important topic with all of us. And Professor Biondi Zoccai, huge pleasure from all of us. I learned a lot. I'm sure all of us learned a lot. I saw a lot of faces which were thinking hard. So I think great stimulating discussions. We would love to have you back. And I think there is definitely room and scope to have dedicated sessions on statistical methods, methodology, to try to learn these things which really a lot of us don't get time or really dedicated sessions to learn. So really appreciate your time so early in the morning. Thank you. And we really hope to have you back again.